Ever been amazed by how quickly, a small cut stops bleeding? It's almost magical, this instant repair system our bodies
It
have.
really is.
But have you ever really thought about the incredible complexity behind that seemingly simple act? How does liquid blood turn into a solid plug at exactly the right moment?
Yeah, it's fascinating stuff.
Okay, let's unpack this, because that's precisely what we're diving into today.
We are indeed embarking on a deep dive into the remarkable process of normal blood coagulation. Our mission today is to unravel how your body manages this critical balancing act.
Keeping blood flowing freely when it should.
Exactly. And forming a solid clot precisely when and where it's needed after an injury. We'll be exploring a range of scientific sources to shed light on this essential system.
Aiming for a thorough yet easily understandable overview.
That's the goal.
Perfect. Because this isn't a passive state. Your body is constantly working to maintain what we call hemostasis. Think of it as a dynamic equilibrium orchestrated by your vascular system. And at the heart of this orchestration is, well, a fascinating interplay between factors that encourage clotting,
The procoagulants,
those that put the brakes on it,
anticoagulants,
yeah,
and those that eventually dissolve the clot.
the fibrinolytic factors. It's a whole system.
It really is.
And to really understand this interplay, we need to introduce the key players, the proteins involved. We can broadly categorize them.
Okay.
First, we have procoagulant proteins. These are the ones that get the clotting process going.
Right.
Then we have anticoagulant proteins, which work to inhibit clot formation.
The brakes.
And finally, there are fibrinolytic proteins, crucial for breaking down clots once they've done their job. Plus, we also have a cast of inhibitors and receptors that act as regulators.
Making sure the whole system operates smoothly and doesn't go haywire.
Precisely. It's all about control.
So let's meet the procoagulants, the initiators of the clotting cascade. A real star player here is thrombin, you mentioned.
Thrombin is absolutely central. Interestingly, the earliest identified clotting factors were labeled with Roman numerals, Factor I, which is fibrinogen, Factor II, prothrombin, Factor III, thromboplastin, and Factor IV, the vital calcium ions.
That's right, the historical context is helpful.
And you'll often see an A after the Roman numeral that indicates the protein is in its active form.
Correct. A for activated.
So understanding these initial labels helps us track the historical understanding, but which of these factors are now considered the biggest players in triggering a clot?
Well, thrombin, the key enzyme we mentioned, is actually the activated form of prothrombin, so factor III.
No.
And when we discuss these coagulation factors, it's essential to recognize the role of vitamin K.
Right.
A specific group of proteins synthesized in the liver rely on vitamin K for their proper function in both promoting and inhibiting coagulation.
The vitamin K-dependent family. Tell us more about them.
Yeah, what's fascinating here is that this vitamin K-dependent group includes both pro-clotting factors like 7-NiX and prothrombin,
The accelerators.
and anti-clotting factors like protein C, protein S, and protein Z.
The brakes again. So vitamin K is involved in both sides.
Exactly. It's crucial for balance. Most of these, in their active forms, are what we call serine proteases.
Okay, what does that mean in simple terms?
These are basically a class of enzymes that work by cutting other proteins at specific places. It's like activating or inactivating them, flipping a switch in the coagulation cascade.
Got it. So vitamin K is like the essential ingredient that allows these proteins to do their job correctly.
Precisely. Vitamin K is crucial for a post-translational modification. Think of it like adding a special finishing touch to a protein after it's been assembled,
Okay.
making it fully functional. It's called gamma carboxylation of glutamate residues, often referred to as GLA.
The GLA.
And this tiny modification, the GLA, is absolutely critical. Without it, these key clotting and anti-clotting proteins simply can't bind calcium ions properly, and they can't interact effectively with cell membranes, which is essential for their function.
And this is where warfarin, that common blood thinner, comes into play, right? It messes with vitamin K.
You got it. Warfarin works by interfering with this very vitamin K cycle. By disrupting the GLA modification, it reduces the activity of those vitamin K-dependent clotting factors.
Making the blood less likely to clot.
Correct. However, the response to warfarin can vary quite a bit between individuals, which is why careful monitoring, like the INR test, is so important.
So these vitamin K-dependent proteins, they have some interesting structures, don't they? You mentioned domains earlier.
Yes, they do. Following that GLA domain, which anchors them, you'll often see other structures, like a Kringle domain or an epidermal growth factor-like domain.
Like different building blocks.
Kind of. These different modules allow them to interact with other molecules in specific ways. For instance, some domains help them stick to cell surfaces where the action happens. And there are slight variations. Protein S, for example, isn't a serine protease precursor. It has a different role as a cofactor. And protein Z has what's called a pseudocatalytic domain. Many of these clotting factors start out inactive, like a dormant enzyme.
Waiting for the signal.
Right. We call these zymogens or proenzymes. They need to be cleaved or cut to become active.
Okay, so we've met some of the main enzyme players, the proteases, but there are also cofactor proteins involved, right? They're not enzymes themselves, but they help the enzymes do their job better.
Precisely. Helpers. We can distinguish between soluble plasma cofactors, like Factor V and Factor VIII, which circulate freely in the blood,
Okay.
and cell-bound cofactors, like tissue factor and thrombomodulin, which are attached to cell surfaces.
Got it. Let's start with Factor V. What's its story?
Factor V is a large protein found both in plasma and actually stored within platelets, too.
Oh, inside platelets.
Yes. It gets activated by thrombin, that central enzyme, again into Factor V. Factor V then acts as a crucial helper, really accelerating the activity of Factor XIII in what's called the prothrombinase complex.
Prothrombinase. Sounds important.
It is. That's the complex that generates the bulk of thrombin. But Factor V's activity is also regulated. It gets inactivated by activated protein C, or APC.
Another control mechanism.
Exactly. And this brings us to the Factor VIII mutation. Have you heard of that?
Vaguely, yes. It increases clotting risk.
It does. It's a relatively common genetic variation where Factor V becomes resistant to being shut down by APC.
So the off switch doesn't work properly.
Right, which leads to an increased risk of blood clots, a prothrombotic state. It really shows how a single genetic tweak can significantly impact this delicate balance.
Wow. Okay, what about Factor VIII? We hear about that in the context of hemophilia.
Absolutely. Factor VIII circulates in the plasma, but it's usually bound to another protein called von Willebrand factor, or VWF.
Why does it need VWF?
VWF basically stabilizes it and protects it from being degraded too quickly.
Ah.
Thrombin activates Factor VIII into Factor VIII, and ADA then acts as a cofactor, boosting the activity of Factor IA in the intrinsic tenese complex.
Another complex.
Tenese.
Yes, intrinsic tenese. It's another critical complex, this one for activating Factor X.
So if you're deficient in Factor VIII,
You can't effectively activate Factor X via this pathway, leading to impaired clotting. And that's hemophilia A.
makes sense. Now let's talk about the cell-bound cofactors. First up, tissue factor, or TF.
Right. Tissue factor is a transmembrane protein, meaning it spans the cell membrane. It acts as a non-enzymatic cofactor with Factor A in the extrinsic tenese complex.
Extrinsic tenese.
Okay. The key thing about TF is that it's normally not exposed to the blood. It's hidden away in the subendothelium, the layer beneath the vessel lining, and on certain other cells.
So why is it hidden?
Because it's the main initiator. When there's injury or inflammation, TF gets revealed, and that's the trigger for the extrinsic pathway of coagulation.
The starting gun. Pretty much. It's so critical that its complete absence is lethal in mice studies. That really underscores its importance.
Wow. So keeping it hidden prevents unwanted clots.
Exactly that. Controlled exposure is the point. Injury or inflammation acts like turning the key, exposing TF, and initiating the cascade locally, right where it's needed.
That makes perfect sense.
Ah.
And the other cell-bound cofactor is thrombomodulin, or TM. What does that do?
Thrombomodulin sits on the surface of intact endothelial cells, the ones lining healthy blood vessels. It has a very high affinity for thrombin.
It likes to grab thrombin.
It does. And when thrombin binds to TM, something remarkable happens. Thrombin's procoagulant activities, its ability to clot blood, are actually neutralized.
It switches sides.
In a way, yes. The thrombin-TM complex becomes an anticoagulant activator. It acts as a cofactor for activating protein C, that key anticoagulant we mentioned earlier.
The one that shuts down factors VIII and A.
Precisely. This thrombin-TM complex, sometimes called protein case, not only puts the brakes on further thrombin production, but also plays a role in slowing down fibrinolysis, the clot breakdown process.
That's fascinating. Thrombin, a key pro-clotting factor, can be flipped to become anti-clotting when it binds to thrombomodulin.
It's an incredible piece of biological engineering, a feedback loop. Interestingly, inflammatory cytokines, signaling molecules involved in inflammation, can reduce TM activity on endothelial cells. This might contribute to the increased clotting risk we sometimes see in inflammatory conditions.
Okay, so these enzymes and cofactors don't just float around randomly, do they? They come together in these specific complexes you've mentioned to really speed things up.
That's a crucial point. These complexes, particularly the ones involving vitamin K-dependent proteins, are essential for efficient hemostasis.
We've heard a few names: extrinsic kinase, intrinsic kinase, prothrombinase.
Right. We have 4 key ones to remember. The extrinsic kinase, VIII, the intrinsic kinase, OXA, the prothrombinase, ZAVA, and the anticoagulant protein case complex, thrombin TM.
And they form on membranes.
Yes, they assemble on membrane surfaces like activated platelets or endothelial cells. This brings the enzyme, its cofactor, and its substrate close together.
And that makes the reaction go faster.
Dramatically faster. We're talking about reactions happening potentially millions of times faster when these components are assembled on a membrane compared to just floating in plasma.
Yeah.
This localization is the body's way of ensuring clotting happens precisely where it's needed and very quickly without causing clots elsewhere.
Now, the names intrinsic and extrinsic pathways often come up. We've talked about tissue factor driving the extrinsic pathway. What about the intrinsic pathway? What proteins are involved there?
The classic intrinsic pathway involves a group of proteins, Factor XII, prekallikrein, and high molecular weight kininoate, or HMWK. Interestingly, and this is important, deficiencies in these particular proteins are generally not associated with bleeding disorders in patients.
Really? So they aren't critical for stopping bleeding after an injury?
It seems not, at least not in the primary sense. The traditional view, based on lab tests where this pathway is initiated by contact with foreign surfaces like glass, well, that view is evolving.
Oh, so.
There's increasing evidence that this pathway, especially involving Factor XII, plays a more significant role in linking inflammation and innate immunity, rather than initiating clotting after vessel injury.
So it's not necessarily a primary driver of normal blood clotting in response to injury.
Not in the same initiating way as the TF-driven extrinsic pathway. However, Factor XIII, another protein sometimes grouped here, seems to be an important intersection.
How does Factor XIII fit in?
Factor XIII can be activated by that initial burst of thrombin generated by the extrinsic pathway. This creates a positive feedback loop.
More thrombin activates Factor XIII, which leads to...
Factor XIII then contributes to the propagation phase by activating Factor IX, feeding into that intrinsic kinase complex. So, while deficiencies in 12, prekallikrein, and HMWK don't typically cause bleeding, Factor VIII deficiency can sometimes lead to increased bleeding, especially after surgery or trauma.
Okay, that clarifies the distinction. This whole process sounds like it could easily get out of hand, though, all this amplification.
It absolutely could.
So what mechanisms does the body have to keep clotting in check, to prevent clots from spreading too far or forming when they shouldn't?
That's where the stoichiometric inhibitors come in. These are proteins that directly bind to and neutralize the activity of the activated clotting factors. Think of them like the dedicated traffic police or the brakes specifically designed for the clotting process.
Okay, the controllers. Who are they?
We have several important ones. Key players include antithrombin, tissue factor pathway inhibitor, and heparin cofactor II.
Let's start with antithrombin, or AT. What does it do?
Antithrombin is a major player, really. It belongs to a family of proteins called serpin serine protease inhibitors.
Inhibiting those serine proteases we talked about earlier.
Exactly. And AT is a broad-spectrum inhibitor, meaning it can target many of the coagulation proteases, thrombin itself, Factor XIII, Factor IX, even the EOTF complex to some extent, plus HEI and 30.
So it hits multiple key points in the cascade.
It does. And people with congenital antithrombin deficiency, meaning they're born with low levels, have a significantly increased risk of developing blood clots or thrombosis.
I see. And heparin, the drug.
Right. Heparin, a commonly used anticoagulant drug, works by dramatically enhancing antithrombin's activity, making it a much more effective inhibitor, especially against thrombin and Factor XIII.
Interesting. Does AT do anything else?
It seems to. There's evidence for some non-anticoagulant properties too, like potentially having anti-inflammatory, anti-proliferative, and anti-angiogenic effects. So it might play broader roles in vascular health.
Okay. And then there's tissue factor pathway inhibitor, or TFPI. What's its target?
As the name suggests, TFTI is the primary inhibitor of the extrinsic pathway, specifically targeting that initial AATF complex.
Starting point.
Exactly. Its action is actually dependent on Factor XIII. TFPI first binds to ZEA, and then this TFPI-ZAM complex inhibits the VAA-TF complex. It's a two-step process.
A bit more complex. Where do we find TFPI?
Most of the TFPI in our circulation is actually associated with lipoproteins like LDL cholesterol. It also has a relatively short half-life in the blood.
Is it critical?
It seems to be. A complete lack of TFPI is lethal in mice, again highlighting the need to control that initial TF trigger. Interestingly, this lethality can be rescued if the mice also have a deficiency in Factor VII. It's all about balance.
That also get.
Always. There's also a rare bleeding disorder called the East Texas bleeding disorder, which is linked to an unusual variant of Factor V that binds extremely tightly to a specific form of TFPI, TFPR. This seems to sequester TFPI, leading to excessive TF pathway activity and bleeding.
Wow, that's specific. And finally, heparin cofactor II.
Heparin cofactor II is another SERPIN inhibitor, but it's much more specific than antithrombin. Its main target is thrombin.
Just thrombin.
Primarily thrombin, yes. And like antithrombin, its activity is greatly enhanced by heparin, but also by another molecule found in the vessel wall called dermatan sulfate.
Any specific situations where it's important?
Its levels are known to change significantly during pregnancy, increasing quite a bit. Low levels have sometimes been associated with conditions like preeclampsia, although its precise role there is still being studied.
Okay. We've talked a lot about proteins floating in the plasma. But the blood vessels themselves, the endothelium, and the platelets also play crucial roles, don't they? They're not just passive bystanders.
Absolutely essential. The endothelium, the inner lining of our blood vessels, and the platelets are critical. They provide the necessary negatively charged surfaces, the anionic phospholipid surfaces, for many of these coagulation complexes to assemble and function efficiently.
And reaction platforms.
Exactly. And they also interact in very sophisticated ways to maintain blood fluidity under normal conditions and promote clotting when needed.
Let's start with the endothelium. It's not just a smooth pipe, is it?
Not at all. The endothelium is a highly active and dynamic tissue. It plays key roles in regulating blood pressure, vascular tone, permeability, inflammation, and interactions with blood cells.
And its role in clotting.
Under normal, healthy conditions, the endothelium is actively anticoagulant. It produces and displays a variety of substances that inhibit coagulation.
Like what?
We've mentioned some already. It has TFPI. It has heparin sulfates on its surface, which activate antithrombin. It expresses thrombomodulin to activate protein C. Protein S is also produced.
So it actively prevents clots from forming on its surface.
Yes. It also produces substances that regulate fibrinolysis, like PAI1, which inhibits clot breakdown, maintaining that balance. However, when the endothelium is disturbed or damaged by injury, inflammation, infection, it can switch gears and become procoagulant. It can lose some of its anticoagulant properties and start expressing things like anionic phospholipids, maybe limited amounts of tissue factor, and even Factor V, promoting clot formation locally. It can also modulate fibrinolysis differently.
So it adapts to the situation.
Very much so.
And then we have platelets, those tiny but mighty cells. What's their main job here?
Platelets are absolutely critical for forming the initial plug at the site of injury, a process called primary hemostasis. But they're also crucial for the coagulation cascade itself, providing that key surface for enzyme complex assembly.
Yeah.
They have various surface adhesion proteins that let them stick to injured vessel walls and to each other, and they contain different types of granules packed with important molecules.
Granules, like little storage bags.
Exactly. Alpha granules, for instance, contain a whole host of relevant proteins. Factor V, fibrinogen, von Willebrand factor, platelet factor IV, even factor XIII. They release these when activated.
So they bring supplies to the site.
They do. In their resting, unstimulated state, platelets keep those procoagulant anionic phospholipids like phosphatidylserine tucked away on their inner membrane surface.
Keeping them hidden.
Right. But when there's vascular injury, platelets go through a rapid series of stages. First is adhesion, sticking to the damaged site, often via collagen and von Willebrand factor.
Good one.
Then comes activation. Signals like collagen, thrombin, or ADP trigger changes within the platelet. They change shape, and crucially, they undergo secretion, releasing the contents of their granules.
Releasing Factor V, fibrinogen, etc.
Yes, and they aggregate, they stick to each other, forming the platelet plug. This aggregation is largely mediated by fibrinogen bridging between activated receptors on adjacent platelets, specifically a receptor called glycoprotein IVIA.
The target of some antiplatelet drugs.
Exactly. And during activation, they also expose those procoagulant phospholipids on their outer surface. This provides the ideal platform for assembling the prothrombinase and intrinsic tenese complexes, leading to that burst of thrombin generation right on the platelet surface.
So the platelets form the initial plug, provide the surface, and release some factors, and then the clotting cascade reinforces it all with fibrin. Let's talk about those final clot proteins.
Right, the structural components. The main players here are fibrinogen, which becomes fibrin, and factor XIII.
Fibrinogen to fibrin. That sounds central.
It is the central event of clot formation, really. Fibrinogen is a soluble protein circulating in the plasma. Thrombin cleaves small peptides off fibrinogen, converting it into fibrin monomers. These fibrin monomers then spontaneously polymerize, forming long strands that create an insoluble meshwork, the fibrin clot. This mesh traps blood cells and reinforces the platelet plug.
Does fibrinogen do anything else?
Yes. Besides forming the clot structure, it's also crucial for that platelet aggregation step we just mentioned, acting as the bridge. And it can even bind thrombin, helping to regulate its activity within the clot. Oh, and interestingly, it's also an acute phase reactant. Meaning its levels in the blood go up significantly during inflammation or infection.
Okay, and the other protein was Factor XIII. What does that do?
Factor XIII is another enzyme precursor, a transglutaminase, that circulates in plasma and is also found in platelets. It gets activated by thrombin in the presence of calcium into Factor XIII.
And its job?
Factor XIII acts like a molecular glue. It introduces covalent crosslinks between adjacent fibrin strands within the clot,
making it stronger.
Much stronger and more stable. It essentially weaves the fibrin mesh together tightly. It also cross-links other proteins into the clot, like alpha-2 antiplasmin, which helps protect the clot from premature breakdown. This cross-linking makes the clot much more resistant to mechanical stress and enzymatic degradation.
Got it. So we have the plug, reinforced by the cross-linked fibrin mesh. But eventually that clot needs to be removed once healing occurs, right?
Absolutely. You don't want clots sticking around forever. That's where fibrinolysis comes in the process of clot dissolution.
And breaking down the fibrin.
Exactly. It's an equally important integrated process. The key enzyme here is plasmin.
Plasmin. Okay.
Plasmin is a potent serine protease that digests fibrin, breaking the clot down into smaller soluble fragments. But like many clotting factors, plasmin exists in an inactive precursor form circulating in the blood called plasminogen.
So plasminogen needs to be activated.
Correct. Plasminogen gets incorporated into the fibrin clot as it forms. Then it's activated to plasmin primarily by two main activators, tissue plasminogen activator, or TPA, and urokinase plasminogen activator, or UPA.
TPA. That's used as a clot-busting drug, isn't it?
It is, yes. Recombinant TPA is used therapeutically to dissolve clots in stroke or heart attack because it's very effective at activating plasminogen.
And like coagulation, fibrinolysis must be controlled too.
Definitely. The activity of the activators, TPA and UPA, is controlled by inhibitors, mainly plasminogen activator inhibitor 1, or PA1.
PA1 inhibits the activators.
Right. And plasmin itself, once formed, is rapidly inhibited if it escapes the clot into the circulation by a very fast-acting inhibitor called alpha-2 antiplasmin.
Keeping the fibrin breakdown localized to the clot.
That's the idea. Interestingly, certain drugs, like lysine analogs, such as tranexamic acid, work by preventing plasminogen and plasmin from binding to fibrin, thereby inhibiting fibrinolysis and helping to stabilize clots in bleeding situations.
Tell us a bit more about the activators, TPA and UPA. Are they different?
They have somewhat different primary roles. What's fascinating about TPA is that its activity is greatly enhanced when it's bound to fibrin.
So it works best right where it's needed, on the clot.
Exactly. This ensures that plasmin generation is largely localized to the clot itself. TPA is primarily synthesized and released from the endothelial cells of the vessel wall, and its release can be stimulated by various factors, including thrombin and activated platelets.
And UPA.
Urokinase. Urokinase, or UPA, also activates plasminogen, but it seems to play a more significant role outside the bloodstream in tissues. It's involved in the degradation of the extracellular matrix.
The scaffolding between cells.
Right, which is important for processes like cell migration, tissue remodeling, and wound healing. While TPA is considered the primary activator within the vasculature for dissolving clots, UPA can certainly contribute and amplify plasmin formation there too.
Okay. And you mentioned the inhibitors of fibrinolysis.
Yeah.
PA1 and alpha-2 antiplasmin.
Yes. PAI-1 is the main physiological inhibitor of both TPA and UPA in the blood. High levels of PAI-1 can suppress fibrinolysis and potentially contribute to a prothrombotic state. Conversely, congenital deficiency of PAI-1 is rare, but can lead to a bleeding tendency due to excessive fibrinolysis.
Makes sense. And alpha-2 antiplasmin.
Alpha-2 antiplasmin is the main, very rapid inhibitor of plasmin itself. It circulates in plasma and quickly neutralizes any free plasmin that might escape the clot, preventing unwanted breakdown of fibrinogen or other clotting factors elsewhere in the circulation. Congenital deficiency is also rare, but causes a severe bleeding disorder.
There's one more inhibitor you mentioned earlier, linked to thrombomodulin, TFI.
Yes, TFI. Thrombin activatable fibrinolysis inhibitor. This one is a bit different. It's a plasma procarboxypeptidase B.
Okay, what does that mean?
It means it's an enzyme precursor that, when activated, chews off specific amino acid residue, lysine residues from protein ends. TFI is activated by the thrombin-thrombomodulin complex, the same complex that activates protein C.
So it connects anticoagulation and antifibrinolysis.
It does. Activated TFI removes those critical lysine binding sites on partially degraded fibrin. Plasminogen and TPA normally bind to these sites to promote efficient fibrinolysis.
So by removing the binding sites,
TFI essentially downregulates plasminogen binding and activation on the clot surface, slowing down clot lysis. It's another layer of control linking clot formation by thrombin to the regulation of clot breakdown.
wow, so it's all incredibly connected, this intricate web of activation, inhibition, feedback loops. How does it all come together dynamically when there's an actual injury? It sounds like a beautifully orchestrated sequence.
It truly is. We can think of the response to vascular injury unfolding in perhaps four main overlapping phases: initiation, propagation, termination, and finally, elimination or fibrinolysis.
Okay, walk us through those phases. What happens first? Initiation.
Initiation phase. Vessel injury exposes tissue factor, TF, on cells beneath the endothelium. This TF binds to the small amounts of activated factor VII that are normally circulating,
Forming that extrinsic kinase complex.
exactly, the VATF complex. This complex is a potent activator of factor X, converting it to ZAC. It also activates some factor IX to IAC. This generates a small initial amount of factor ZAC,
Just a little bit.
a relatively small amount because this complex is quickly inhibited by TFPI, as we discussed. But this initial ZA, along with its cofactor VIII, which might be present on activated cells or platelets, forms a small amount of prothrombinase complex.
Generating a bit of thrombin.
Yes, a crucial initial burst of thrombin. This initial thrombin is key because it does several things. It activates platelets, making them stickier and providing that surface. It activates the cofactors Factor V and Factor VIII, getting them ready for the next phase. And it also activates Factor FF.
So it's like setting off a tiny spark that primes the system for a much bigger reaction.
That's a great analogy. It sets the stage.
Okay, so what happens next? The propagation phase.
Right, propagation or amplification. Here, the action shifts largely onto the surface of those activated platelets. The factor I say generated earlier now combines with its cofactor, the newly activated factor eta, on the platelet surface.
Forming the intrinsic kinase complex.
Yes, and this intrinsic kinase complex, I say eta, is a much more potent activator of factor X than the initial VATF complex, and importantly, it's not directly inhibited by TFPI.
So it bypasses that initial control mechanism.
Exactly. This leads to a large-scale production of factor VIII right on the platelet surface. This is why hemophilia A, factor VIII deficiency, or B, factor AX deficiency, results in poor clotting. This crucial amplification step is severely impaired.
Makes sense, so lots of ZI is generated.
Lots of ZI. And this factor ZI then immediately complexes with its cofactor, factor VA, also activated by thrombin and available on the platelet surface, to form the prothrombinase complex.
The thrombin factory.
The major thrombin factory. This prothrombinase complex, ZAVA, on the platelet surface is incredibly efficient, converting large amounts of prothrombin into thrombin. This leads to the thrombin burst.
And being on the platelet surface protects it.
It does. These membrane-bound complexes are relatively protected from fluid phase inhibitors like antithrombin, ensuring rapid and localized thrombin generation sufficient to form a stable fibrin clot.
Okay, a massive burst of thrombin, forming the fibrin clot. But how does the body know when to stop? How does it prevent the clot from growing indefinitely? That's the termination phase, right?
Exactly. Termination. Several things happen. As the fibrin clot forms and covers the injury site, it can limit further access of clotting factors. Also, as thrombin generation peaks, the concentration of inhibitors starts to catch up.
Antithrombin and others start clearing the active factors.
Yes. Antithrombin neutralizes thrombin and factors I that diffuse away from the platelet surface. And crucially, any thrombin that escapes the immediate vicinity of the clot and reaches areas of intact, healthy endothelium encounters thrombomodulin.
Ah, the switcheroo mechanism.
Right. Thrombin binds to thrombomodulin, its procoagulant activity is neutralized, and it now activates protein C. Activated protein C, APC, along with its cofactor protein S, then efficiently inactivates the cofactors of VIII and VIII.
Shutting down both the prothrombinase and intrinsic tenese complexes.
Precisely. Putting the brakes on further thrombin generation. The thrombin TM complex also activates TFI, which, as we know, dampens fibrinolysis. So, termination involves both inhibiting procoagulant factors and activating anticoagulant pathways.
A multi-pronged approach to shut it down.
Absolutely. It ensures the clotting process is confined both spatially and temporally.
Okay, finally we have the elimination phase, where the clot is eventually broken down.
Yes, elimination or fibrinolysis. Once the vessel wall is repaired, the fibrin platelet clot needs to be removed to restore normal blood flow. This is mediated by plasmin.
Generated from plasminogen by TPA.
Primarily by TPA, which binds to the fibrin within the clot. As plasmin digests the fibrin mesh, the clot gradually dissolves into soluble degradation products, which are then cleared from circulation.
Does plasmin do anything else?
It's also thought to play a role in the broader tissue repair process by activating certain matrix metalloproteinases, enzymes that help remodel the damaged tissue around the clot.
So it's not just about removal, but also about cleanup and repair.
Exactly. It's crucial that all these phases, initiation, propagation, termination, and fibrinolysis, are tightly coordinated and regulated. Any imbalance can lead to either excessive bleeding, hemorrhage, or inappropriate clotting, thrombosis. The body actually initiates the fibrinolytic response almost simultaneously with the procoagulant response, ensuring the tools for eventual cleanup are there from the start. It's a truly dynamic, interconnected, and beautifully regulated system.
It really is incredible. All this complexity happening seamlessly, usually, in our bodies all the time. Now, shifting gears slightly, how do doctors even begin to figure out what might be going wrong if someone does have a bleeding or clotting issue? Given all these moving parts, what kind of tests are used to monitor this delicate balance?
That's a great practical question. Most of the standard clinical laboratory assays used to assess hemostasis focus on the ability of blood plasma to form a fibrin clot after adding certain triggers.
Like the PT and APTT tests.
Exactly. The prothrombin time, PT, the activated partial thromboplastin time, APTT, and also the thrombin time, KT, are common examples. These are workhorse tests in hematology labs.
What do they tell us?
They primarily give us information about the initiation phase of coagulation, how quickly the cascade gets started under specific artificial conditions. They measure the time it takes to form that fibrin clot.
You said there's that big propagation phase, too.
Yeah. Right, and that's a limitation. These rapid endpoint clotting time tests capture only a small fraction, maybe less than 5%, of the total thrombin that's ultimately generated during the propagation phase.
So they don't give the full picture.
Not the complete kinetic picture, no. That's why there's been a lot of interest in developing and refining assays that can capture the propagation phase, giving a more holistic view of thrombin generation potential. It's like looking at just the starting gun of a race versus watching the whole event unfold, including the main sprint.
Okay, let's break down some of those common plasma clotting tests first. What exactly is the prothrombin time, or PT?
The PT specifically evaluates the extrinsic pathway triggered by tissue factor and the subsequent common pathway, factors X, V, prothrombin, and fibrinogen.
How is done?
It's performed by adding a preparation containing tissue factor and calcium ions to a patient's plasma sample and then measuring the time in seconds until a fibrin clot forms.
What's it used for?
It's very commonly used to monitor oral anticoagulant therapy with vitamin K antagonists like Warfarin.
The INR test.
Yes, the result is typically reported as the International Normalized Ratio, or INR, which standardizes the PT result across different labs and reagents, making warfarin dosing safer. The PT-INR is also used to assess liver function, since the liver makes many clotting factors, and to screen for inherited or acquired deficiencies in the extrinsic or common pathway factors.
Any limitations?
It might not be sensitive enough to detect mild deficiencies in some factors, and it doesn't reflect platelet contributions since it's done on plasma.
Okay. And the activated partial thromboplastin time, or APT, how is that different?
The APTT assesses the intrinsic pathway, factors 12, 11, X8, and the common pathway. The key difference from the PT is that no tissue factor is added.
How's it triggered?
Instead, the plasma is incubated with a negatively charged surface activator, like silica or kaolin, to trigger the contact factors, factor 12, etc., along with phospholipid, which substitutes for platelet surfaces, and calcium. Then the time to clot formation is measured.
What's the APTT used for?
It's used to screen for deficiencies in the intrinsic and common pathways, helping to identify congenital defects like hemophilia A, factor VIII, and B, factor IX. It's also the standard test for monitoring therapy with unfractionated heparin. And it can be prolonged by certain inhibitors, like the lupus anticoagulant.
Got it. What about the thrombin time, or TT?
The TT is a much simpler test. It directly evaluates the final step, the conversion of fibrinogen to fibrin.
How?
You just add a standardized amount of thrombin directly to the patient's plasma and measure the time it takes to clot.
What does that tell you?
It's very sensitive to the presence of thrombin inhibitors, like heparin or direct thrombin inhibitor drugs, for example, dabigatran. It's also prolonged if there are abnormalities in the fibrinogen molecule itself, either low levels or dysfunctional fibrinogen, or high levels of fibrin degradation products, which can interfere with fibrin polymerization. It helps distinguish if a clotting problem is due to poor thrombin generation versus inhibition of thrombin or problems with fibrinogen.
Okay. You also mentioned newer tests looking at the bigger picture, like thrombin generation assays or TGA. How do they work?
Yes, TGAs aim to provide that more comprehensive view. Instead of just measuring the time to initial clot formation, they measure the kinetics of thrombin generation over time after stimulation, usually with TF.
So you see the whole curve.
Exactly. You add a trigger and a fluorescent substrate that thrombin acts upon. By monitoring the fluorescence change over time, you can plot a curve showing the lag phase, the rate of thrombin generation, the peak thrombin level achieved, and the total amount of thrombin generated, often called the endogenous thrombin potential, or ETP.
What's the advantage?
It potentially gives a much better overall assessment of a patient's tendency towards bleeding or thrombosis, reflecting both pro- and anticoagulant influences. These assays are being increasingly used in research in specialized settings and adapted for use in whole blood as well.
Interesting. Now, beyond the plasma clotting factors, we know platelets are crucial. Are there tests specifically for platelet function?
Absolutely. Assessing platelet function is important for diagnosing inherited platelet disorders, predicting bleeding risk in some situations, and monitoring the effectiveness of antiplatelet therapies, like aspirin or clopidogrel.
What's involved?
Well, a simple platelet count is usually the first-line test, just checking the number of platelets, but measuring their function is more complex as they do so many things: adhesion, activation, aggregation, secretion.
Right.
Various methods exist. Platelet aggregometry is a classic technique. It involves adding different agonist substances that normally activate platelets, like ADP, collagen, or thrombin, to platelet-rich plasma or whole blood, and measuring the extent of platelet clumping or aggregation, usually by changes in light transmission.
What can that diagnose?
It's helpful for diagnosing inherited platelet function disorders like Klansman thrombasthenia or Bernard-Soulier syndrome, and also some acquired platelet defects. But it can be affected by many drugs, like aspirin, and it doesn't perfectly mimic the complex flow conditions inside a blood vessel.
Are there other ways?
Yes, there are specialized instruments designed to simulate aspects of platelet function in vitro under more physiological flow conditions. Examples include the Platelet Function Analyzer, PFA 100200, which measures the time it takes for platelets to plug a hole in a membrane coated with collagen and ADP or epinephrine under high shear stress.
Is that better?
It's a useful screening tool, particularly sensitive to von Willebrand disease and the effects of aspirin, but it can be affected by low platelet count or low hematocrit, and its ability to strongly predict clinical bleeding risk is still debated. Other analyzers exist, like the Verify Now system, often used to monitor specific antiplatelet drug effects. Flow cytometry can also be used to look at specific platelet activation markers or receptors.
It sounds like measuring platelet function robustly is still a challenge.
It is, yes. Finding a single test that captures the complexity of platelet function in vivo remains elusive.
And you mentioned earlier there was renewed interest in using whole blood assays more generally. Why is that? What's the benefit?
Whole blood assays are appealing because they allow all the components of blood plasma factors, platelets, red cells, white cells to interact naturally during the test, potentially giving a more physiologically relevant picture of clot formation than plasma-based tests alone.
Makes sense. What are some examples?
One common point-of-care whole blood test is the activated clotting time, or ACT. It's essentially a modified APTT performed on a fresh whole blood sample, usually at the bedside.
Where's ACT used?
It's widely used during cardiac surgery or interventional cardiology procedures to monitor the anticoagulant effect of high doses of unfractionated heparin, allowing for rapid dose adjustments. It can also be affected by direct thrombin inhibitors. It provides immediate information in critical situations where you need to manage anticoagulation intensity closely.
And finally, you mentioned thrombolistography or tegrotym. That sounds intriguing. How does that work?
Thrombolestography is quite different. Instead of just measuring the time to clot, it measures the physical properties of the developing clot in whole blood over time. Basically, a small sample of blood is placed in a cup or cuvette, and a pin is suspended in it. As the blood clots, the developing fibrin strands physically connect the cup and pin. The instrument measures the torque or resistance generated as the clot forms and strengthens, and sometimes as it lyses.
What does the result look like?
It produces a characteristic tracing, a thromboelastogram, which provides information about different stages of clotting. The time it takes for the clot to start forming, R time or CT, the speed of initial clot formation, K time, alpha angle, the maximum strength or stiffness of the clot, maximum amplitude or MA, and potentially clot lysis or breakdown, Li30.
So it gives a dynamic picture of the whole process.
Exactly. It assesses the interplay between clotting factors affecting RCT, platelets and fibrinogen affecting MA, and fibrinolysis. TEG and ROTEM, a related technology, are increasingly used in various clinical settings: trauma resuscitation, cardiac surgery, liver transplantation, obstetrics to guide transfusion therapy in real time, helping decide if patient needs plasma, platelets, or cryoprecipitate. They can even be modified with specific activators or inhibitors to assess platelet aggregation or the effect of anticoagulants.
It's truly astonishing how many layers there are to this fundamental process, from the very first molecular trigger to the final dissolution of the clot, and equally amazing how many sophisticated ways we've developed to try and monitor and understand it when things go wrong.
Indeed, the delicate dynamic balance between pro and anti-clotting factors, the intricate dance between plasma proteins and cellular components like platelets and the endothelium, it all has to work just right. And the monitoring methods, while still evolving, reflect our attempts to grasp that complexity and apply it clinically. It really highlights the remarkable efficiency and elegance of this system in maintaining vascular integrity most of the time.
So, considering this incredible, almost mind-boggling interplay of all these factors we've discussed, it really makes you wonder, what might be some of the more subtle, yet perhaps significant ways that disruptions to this finely tuned system could manifest, maybe beyond the obvious major bleeding or clotting disorders? Are there broader implications for chronic health conditions, maybe inflammation, maybe even things like cancer progression or neurodegenerative diseases, where subclinical alterations in coagulation or fibrinolysis might be playing a role we're only just beginning to understand? That's certainly something to ponder.
It absolutely is. The connections between coagulation, inflammation, immunity, and even vessel growth are becoming increasingly apparent.
Well, if any particular part of this deep dive, maybe the intricacies of platelet activation, the role of specific inhibitors, or the latest in monitoring tech has sparked your curiosity, we definitely encourage you to explore those specific areas further. There's always more to learn.
Always.
Until next time, keep those questions flowing.